and you'll find me doing a wider local injection on a bigger patient with one poke, but underneath the skin, I'm doing a wide localization so that I have room to what I call fish in there. If you've got to go fishing for that space, you want to be able to localize. The most important area to localize is the very superficial. That's the most innervated point. That's the part that's the most uncomfortable for them. Usually after that, it's just pressure, but it can be pretty sensitive pressure, and even to the point where it's painful pressure. Anyway, so local anesthesia, I'll throw this back into an area of my tray that I can make dirty. Even though it's technically not dirty, because it's all still sterile if I needed to reuse it. Or if I needed to drop some more local, because there's 5 cc's here, it's only a 3 cc syringe, so I've got 2 more cc's I could use if I wanted to. Okay, at that point in time, I'm gonna pick up my 2E needle, or whatever needle it is. Bevel's gonna be up, and these needles are dull on purpose, because it wants to give you the tactile feel of going through those layers. And sometimes it will crunch and pop as you insert this needle, and they will hear that. And some people will freak out. What the heck is that sound? So I've got my thumb on the spinous process again. I know where I can see it might be bleeding a little bit where my local went in. I'm gonna insert my needle. You've got your markings. I typically insert it, depending how deep is how big the patient is. If they're little, only a couple of centimeters, and then I'll pull out my stylet.
Each mark is a centimeter.
Yes. Yep. If they're bigger, I'll push it in further initially. Some people will even push it till they think they feel ligament flavum. So you've already gone through what 2 ligaments to get to ligament flavum? Supraspinous and interspinous. Ligament flavum's typically the toughest of the 3. Most people, you can feel that ligament. It gets really stiff all of a sudden, and even in some people, older patients, you can confuse it as bone. And so it's very common to feel that ligament. It gets really tough and strong. I typically don't get that aggressive in trying to push my needle all the way into ligament flavum from the beginning. I'll just go several centimeters in to where the needle is not gonna fall out if I let go. It's gonna stay. I'm gonna pick up my glass syringe, and again, I'm using air, but you guys will use saline in a bubble. I'm gonna push it onto the needle, and I don't know if you guys can see how I've got my hand against their back, and I'm pinching the needle right at the hub as I push this, because I don't wanna push on this slip tip needle and be like pushing the needle in accidentally, just trying to get the syringe on. So you want to stabilize your 2E needle with your hand and pinching to push this on. And I will tell you, I don't know if this has happened to Dan, he's so good it probably hasn't. If you don't have a good connection here and you're pressurizing this as you're going, sometimes it will pop off and local anesthetic or saline will squirt all over you.
Scare the crap out of both of you. Is that a slip tip or a lure lock tip?
This is a slip tip.
So some of those glass syringes are a lure lock. So that can't
You
happen.
screw it on.
Screw it on, they're good to go. I hate the slip tip for that exact reason. Because some people might be really tough when you're giving a little bit of forward pressure with that plunger, and there's so much pressure it pops the glass off the needle, and like I said, it scares you both.
Yep. And if you're doing that during a spinal, and you've got to the spinal space, it's dripped out, you put on your syringe with your local anesthetic, and you start pushing that in and it pops off and squirts out. Now you're like, how much local actually went into the space? How much local went out? Is it gonna be enough for the procedure? Should I grab more? All these thoughts start going through your mind. Oh crap. That brings up another story I can tell about in a minute. You guys remind me. Tell us the story about the spinal local anesthetic. I'll remember. Okay, anyway, so push that on tight, slip tip. Now I'm gonna start bouncing the needle, and on this model, it's not gonna, this one pushes through. It shouldn't push through. It should push, create pressure, and it should come back, especially when you get to ligament flavum. So you should have pressure on your needle. As you've got pressure on that needle, And this is where some people are different too, where they'll do a constant pressure and advance their needle versus bounce, check their pressure, push in a little bit, feel it, bounce, check their pressure, push in a little further, bounce, check the pressure, push in, all of a sudden, oh, it's really tough now, this is probably ligament flavum. You're gonna push, oh yeah, it creates a lot of pressure in there with ligament flavum.
What grip does he have with his left hand on that needle? What's it called? Fromage. That's right.
See, I don't even know that. I remember you talking about it when you gave the lecture, but I don't remember that. It's just you learn by mistake of accidentally pulling out a needle or advancing a needle accidentally how to hold it. Anyway, well this, I don't even know if this model, does it have ligament that I'm gonna feel?
In theory.
In theory?
Like 20
Just like the central line.
Like 20 years ago.
In theory.
I just stuck my finger in there, the central line.
Good year.
It was just
Like, I'm not sure on this.
Way to go.
We'll get into it.
Cut yourself?
Apparently, I bet it was the edge of this glass on this syringe. Got one of my fingers and I didn't even feel it.
She's clean.
No, she's the one that needs to be worried. Anyway,
Good one.
once you get through that ligament, if you feel it and it's tough, once you get through, you literally, loss of resistance should be, what the crap?
Blood everywhere.
You will get, I know it was the edge of this glass. You will get a pop where your syringe will just lose all resistance. And so it's very significant loss of resistance.
You don't inject everything in there though, right?
No, but if you're doing constant pressure and you all of a sudden get that loss, you'll feel it. Now, for air, no, usually, but if you've got saline, some people will use saline to expand the space before they put local anesthesia in. Gauze in there? No. Okay, so loss of resistance, you're where you're at. What if I was advancing this needle and they're like, oh, I feel that on the left side, I feel that on the left. What are you gonna wanna do?
Go back and go
Yeah, redirect a little bit. Now, sometimes depending what depth I'm at, I don't even necessarily pull back. I might just push my needle over and keep advancing a little bit further. But yeah, you'll technically wanna pull back, redirect, opposite of whatever direction they were just complaining about, left or right, and then start advancing forward again until you get that loss of resistance. Once you get loss of resistance, then you're gonna take your catheter, and this one's really weird.
Don't talk about the markings on the needle.
Oh, yeah. I did. So, 1 centimeter each one. I'm gonna pull this out. Most of them are, these needles are 3.5 inches standard. And so you could count 1, 2, 3, 4, 5, 6, 7. So depending how deep you are when you get loss of resistance, you'll know how far it is. So let's say I got loss of resistance there. I'm like 2.5 centimeters from the bottom of 7, 8 centimeters. So you kind of know where your distance is. So now, if you ever had to redo this for any reason, and you chart this on your chart, depth to the loss of resistance, because if you have to come back and redo an epidural, it gives you a good indicator of how deep you need to go to get to that spot.
So how far, sorry, Ted, how far do you want the epidural catheter thread in the epidural space?
3 to 5 centimeters.
Okay, go with about 5. That
Yeah.
way, if you go with 3 and they back out a little bit, you're gonna be real shallow. So you wanna usually thread that about 5 centimeters in the epidural space. So if it took 3 to get in and 5 to go up, at the skin, what number are you gonna see, or how many? 8. Okay?
People will try that, and people chart it a different way, but that's what I was just gonna say. Once you thread the catheter in, let's say 5 centimeters, then you add your centimeters of depth, and that's your total distance. Now, if you have a big patient, and I know Dan talked about this, where you're buried the needle, and then even pushing their hub in against their skin, and you have to hold it, because if you let go, their skin retracting back out will pull your needle out of their space. So you may have some really deep epidurals. The deepest one I remember was 13 centimeters for me. I don't know if you've got a number out there. And so you're talking a 5-inch needle, buried hub, and then threading the catheter in as well. And I'm talking 13 centimeters of needle, not needle and catheter. so it was deep. You'll thread your catheter, and so, and a lot of them come like this? I've never seen this for an
Yeah,
epidural catheter.
now they do.
Really?
Yeah, it was.
These catheters are very soft and flimsy. They used to be almost a stiffer catheter, which was a lot easier to thread a stiffer catheter. You could just grab and thread it easily. The problem with stiff catheters, like Dan said, is they would go right, left, and commonly they'd go down rootlet, or they would go intervascular. Now that they've gone to these really flimsy, soft catheters, you rarely get blood in your catheter. They tend to just go in, and who knows where it's going. It might go in, go right, then it might circle a little bit. The tip of it's gonna seed somewhere, and then the rest of it's gonna loop around in there. You really have no idea where it's gonna go. Sometimes they'll get a paresthesia with this, meaning, oh, I feel that on the right side, or oh, I feel that on the left side. I don't worry about getting a paresthesia threading the catheter. With needle placement paresthesia, you're gonna wanna redirect. With catheter placement, you're gonna get a paresthesia. The only thing that concerns you about threading this is if you get a constant paresthesia that doesn't go away. Then you're gonna wanna pull, should you pull the catheter out of the needle?
No.
Why?
You can have fragments.
Yeah, it could shear, right? So if you're gonna wanna replace your catheter, you gotta pull everything out and start over, if you get a constant paresthesia. It's very common to thread this in, to get a paresthesia, and then, it goes away, and then I just leave it. I'm a little bit different with Dan with the soft catheters. I've gone to a point where I will thread in further than 5 centimeters, especially if they're a bigger patient. I don't remember who asked the question about them falling out. Maybe it was Brittany, I can't remember. But the bigger patients are more common for catheters to work themselves out of the space. And you won't know it by looking at, you might want to look at the back and be like, oh, the catheter hasn't moved at all. But underneath their skin, because of all that, if they've got that thick tissue that with gravity moving around and rolling side to side, when they're laying in this position and you take the catheter, it may sit at 8 cc's. They lay down and roll on their right side, and that tissue pulls because of the size. It now might have pulled that catheter out of the epidural space 2 centimeters, but where you're still in 5 centimeters if you threaded 7. If you're barely into the space and they roll and pull out, now that tip pulls all the way out of the epidural space, but on the skin you don't notice it. You would never notice it. And you may go in to replace it and pull it out, and as you're pulling it out, it's like, oh wow, it was in there, it was in the skin, but it may have pulled out of the epidural space, if that makes sense. And so on bigger patients, I will thread these soft tip catheters a lot deeper to try to prevent that.
If you see it on a test, the answer's 5.
What?
If they see the question on a test, the answer is 5.
Oh, 5, yes. 5 centimeters.
Or it can be a
Wink, wink.
type in, type text. 5,
It's
maybe
not-
10.
it's not a type in.
Depends.
Short answer there for 10.
Yeah.
Hey Ted,
Yeah.
since your catheter there is pretty limp, is it likely to kink?
I like
What are
that.
you
I
saying
like
about
that.
my catheter?
I like that description.
Anyway,
Will it kink could it kink in the epidural space?
yes, absolutely potential. It's unusual, but potential. But you will find like the old stiff catheters, you could grab several inches back and thread it through the needle. These ones, you have to grab close to the hub of the needle and just thread it little bits at a time, otherwise it's just too flimsy.
And it may take a couple attempts
Yeah,
of trying to move that catheter, right? Don't think just because you're up against a wall at first, you're not in the right spot.
Yeah.
Sometimes it just takes a couple attempts to get that thing in there.
and that's what I was gonna say. If the catheter doesn't go easily into the space, you're most likely in the wrong spot. And so if you don't get a definite loss of resistance, you're like, and you'll get people, like I said, it's usually pretty significant for most people. You will have some people that are so spongy, you're like, I think that might have been lost, but I'm not sure. But if you go further, you're wet tap, so you're like, okay, I'm gonna assume it was lost. So I go to take my catheter and I try to thread it, it will not thread past the tip of a needle. That right there is an indicator, it probably wasn't lost, you're not in the right space. That catheter should easily spread into that space most of the time. There are some times where initially you might need to get it in there, and then all of a sudden it threads really easy.
So if that happens, in the hub of that needle, it's clear, your catheter, there's a dark black line, you can tell when your catheter is at the tip of the needle. So if you are right there, you can see, okay, my tip of the catheter is not going past the tip of the needle. You can pull the catheter out, cause it hasn't gone through the tip, so you're not gonna shear it. You can pull that out, put your syringe back on, and go a little bit further.
Like this, and every catheter could be different. This one's got two marks together that I'm guessing is probably at the end of the needle. I was to make a guess. Oh, so it's the start of this solid long line. The start of it is the tip of your needle. Okay, so anyway. There's my loss of resistance. Anyway, so I just threaded the catheter. Now, at the same time, you've got to hold the very end of the catheter like a centimeter out, and you're going to push it forward and pull your needle out. Push it forward, pull your needle out. And if you know where you're marking your catheter is, your depth of your needle is, you know how far in your catheter is, you're going to push it in, pull it out, push it in, pull it out, push it in, pull it out. Once the tip of the needle comes out, you're going to pinch the catheter, pull the needle all the way off. Now you can look at your markings on your catheter and be like, oh, I actually, doing that process, I just made it 2 centimeters deeper. So you might pull it out 2 centimeters. Or vice versa, you might be like, oh, it came out a centimeter. I'm gonna try to push it in a centimeter. You may not be able to push it in very well, but you can try. Sometimes you can, sometimes you can't. Anyway, if you're not worried about it, even though it may have came out a centimeter, if you think you're still deep enough, which if you put in 5 centimeters, you might still be at 4 centimeters. You're now gonna tape it. Well, before I tape it, I actually test dose it. So now you're gonna take your syringe. You're gonna, and usually I have this done before, drawn up your test dose, at least 5 cc's. You're gonna at least give 3 cc's. You're gonna connect however your connector works, and I'm not sure how this one works. You're gonna connect it onto the end of your catheter. You're gonna secure it with its system, however it works. This one probably pushes like that.
Yeah, slightly it opens.
And then you're gonna take your test dose, you're gonna put it onto the end of the catheter. And then you're gonna talk about a test dose. What do I wanna tell my patient for the test dose?
Let me know if you've had a tingle or numb fluid sensations.
Okay, that's part of it. What else?
Rushing noise
Lightheaded.
in the ears.
Ringing in the ears, okay. What else? What'd you say?
Metallic taste.
Metallic taste, which is indicative of what? Huh? I hear whispering.
So let's just review really quick then. So the epidural catheter can be in basically one of 3 places, right? Epidural space, which is hopefully where you're at, you don't need to worry about it. The 2 other places are where?
Intravascular.
Intravascular or
Spinal.
spinal. Okay, so let's go intravascular first. You have 2 ingredients in your test dose. You have epi and lidocaine. So if you are intravascular, what is the test dose going to do with those 2 ingredients?
Increased heart
Okay,
rate.
so they're hooked up to the SAB probe, so you can listen to that increased heart rate, hopefully timed in between contractions. And if it goes up more than what, are you gonna be worried?
30%?
I think 20%, I think is the
20?
book, 20 to 30%, we'll go with that. Okay, so that's the epi. What is the lidocaine gonna do?
Within 30 seconds, right?
Yeah.
It's pretty significant and it's pretty quick.
Or is it
Okay,
3
what does the
seconds?
lidocaine do?
Lightheaded.
Okay,
Numbness, like a nut.
it gives you that other stuff, circumferential numbness, the ringing in the ears, right, that's what that
Metallic
does.
taste.
Okay, metallic taste in your mouth. So I tell my patients, if you get a metallic taste in your mouth, lips get number tingly, or you feel like you're peeing your pants, because that's gonna be the next one, right? So that's venous. Now let's go intrathecal. So now you're in the spinal space. Let's say you've gone too far. What is the epi gonna do for you? Okay, good, jack squat. What's the lidocaine gonna do for you?
Get with the spinal, basically.
Spinal.
Okay, that's right, it's gonna make them
Which
feel
is
like
what?
they're peeing their pants,
Yeah.
right? It's a nice little.
Well, why does it feel like they're peeing their pants?
Because it's like the tingle.
Yeah, they're going numb, but there's also what does it knock out first? What nerve fibers?
Both.
Well, more specific, like when we talk about A, B, C, D,
Sympathy.
temperature ones, right? And so they get that temperature change, and they also get that warm sensation. They're like, which feels like warm urine dripping down your areas, right? You're like, holy crap, did I just pee my pants? On top of them already probably being ruptured and like leaking fluid anyway. So that's the feeling they get. They get that warm sensation, and because of, this is probably technically high power isobaric, I'm guessing. It might even be hyperbaric and sink a little bit because of the position. So that's the sensation again. Okay, so that's what you're gonna tell your patient to look for. And then you're gonna inject at least 3 cc's. If I have more, I'll inject more. I'll just put somewhere between 3 and 5 cc's in there.
Do you aspirate first?
Yes, always, sorry, I didn't say that. So I always aspirate on the end of the catheter, and if you get blood, obviously you're gonna, this is another slip tip for you. As you aspirate, you gotta hold it because it's a slip tip. If you get blood, obviously you're just gonna pull it out and start over, like Dan mentioned earlier. If you get fluid into your syringe and starts filling up your syringe, you're probably intrathecal. Pull out and start over. But if you don't get anything, and you might get a little bit of local in there, but if it's in the CSF, it'll just kind of continuously fill. Where the local, you might get a couple of drops or a CC, so don't confuse that for CSF. It's gotta be kind of a continuous fill in your syringe. But if you don't get any of those, then you're gonna inject your 3 to 5 cc's. How long do you wait?
3 minutes, 3 to 5 minutes.
Yeah, that's what I was.
3 to 5 minutes before you dose with your local anesthetic. So there's a lot you can be doing in between then. But if you're intravascular, you're gonna know within 10 seconds, especially, and you should have don't just let your nurse put the pulse ox on, but make them sure they put it on and they turn the volume up so you can hear it. Because you may not be able to see the pulse ox, because it'll be on the other side of the bed, down underneath in the cart. You wanna be able to hear it. If you hear it within 10 seconds, you'll usually hear the pulse rate go up first before the patient will be like, oh, I don't feel very good. Oh, I'm feeling lightheaded. Oh my gosh, my ears are ringing. And so the pulse ox is usually the first thing you're gonna hear going up, and then you're gonna start over. No, pulse ox doesn't go up, they don't get the numb, tingly, warm sensation. Test dose is negative, you're gonna chart it as test dose is
So
negative.
intrathecal takes a little bit to set in.
It takes a little
The
longer,
test dose.
yeah, it's still quick compared to like an epidural setting up, right? It's like 5 minutes, but that's where your time waiting is not for the intravascular part, it's probably more for the intrathecal part to make sure you're not intrathecal. And so that'll, so if your intravascular is negative, I'll start taping. Obviously before I inject local, I'm not gonna inject local until I clarify there's no negative, or that it's negative on the intrathecal part. So you have this little sponge. Everybody does this differently, but typically these sponges have a split in it. I don't know if you guys can see that, or if you look in your own kit. So some people will do this different. Some people will create a loop on the catheter. This is a sticky on it. They'll take that sticky off, put it right above the loop. They'll loop the catheter out the back, down, and then they'll put the catheter in that split as it comes up, and then they'll tape it down, and that's just a way to secure it. I personally don't do it that way. I put a loop in my catheter, and then I stick the whole stick right over the incision in the loop, like that. I don't even use the split in the catheter. And then I just tape you'll have a tegaderm, which doesn't come in your kit usually. You have to open it separate, throw it in, or have your nurse get it for you. Put some kind of tegaderm on it. It's always nice to have a clear film around it so that when you check it multiple times, you can see if it's bleeding or if the catheter's been pulled out or changed position at all. So it's usually some kind of clear occlusive dressing. Put it on, and then you're gonna take some kind of tape. A lot of people usually call it the toilet paper tape. It's called, what's it called? Its technical name, ribs.
Yeah. Can you go over that too?
Anyway,
We'll start the next class.
oh my gosh, the time already?
Yeah, and there's your spinal kit too.
Great. You're gonna take your tape, and I tape all the way around the occlusive dressing in a square, and then I tape the strip with the catheter right down the middle of it, all the way up to the top of their shoulder. And then some people on the front side will even put a couple loops in it, and then put tape on their gown, and so, or their skin directly, one of the two, so that it's secured here, all the way down their back, and then all the way around. Nothing do moms hate worse than their catheter getting accidentally pulled out for whatever reason, right as they're delivering, or shortly before they deliver, and you don't have time to put another one in. So it's secured multiple ways. Once I know my test dose is in, I'm gonna load my local anesthetic. And this is different, facility dependent on what you're gonna give. Most of the time I would do 0.5% bupivacaine without epi, 10 cc's. I do 5 cc's at a time. I give 5 cc's, and then I would lay them down, position them, left lateral tilt. As I'm doing the charting paperwork, then I'd give another 5 cc's 5 minutes later. They usually by then are starting to feel, oh yeah, I feel it coming on. That contraction got a little bit less, and then they kind of just get less and less. They're not going away, they're just feeling less and less of them. The goal is hopefully for them to feel just some light pressure with contractions. Oh yeah, I can tell I'm contracting, but it doesn't hurt. That's kind of the goal. The infusion pumps are gonna be different too with what people dose. It's anywhere between 0.25% to 8%. To 1/16% with narcotic in it. A lot of places will use a little fentanyl in it because it will make your block work better. But it does have side effects. That's where you get your itching from the fentanyl in your blocks. But anyway, that's epidural placement. What level do we typically need for labor patients?
T8. Is that L4?
Well, that's
Is
that's
it
not
the
epidural
umbilicus?
placement.
It's T12.
Oh, level, or is it higher?
Yeah, level. We're talking
Oh,
dermatome,
okay.
sorry. Dermatome
Dermatome.
level.
So it's not T6, it's T10.
T10, yeah, which is umbilical roughly. T10 down to L2 for first stage. Once they transition and start getting into like third stage, what areas are you hoping to cover? Where's their pain?
Lower.
Lower. Their pain's gonna be lower. It's gonna be in the cervix. So what nerves cover that area? Cover your toes too. Lumbar, or I mean, no. Sacral. Sacral plexus. So the first part of labor, first half to first 2/3 of labor are gonna be coverage that you're gonna want from T10 to like L2, L3, L4, and then third stage labor or transitioning. Once they start transitioning, as the head starts coming down the canal, it kind of all switches. And that's why a lot of women, and I don't know, you moms may be able to verify this, will say, my epidural stopped working at the end. And it's because they transitioned from your coverage might have been T10 to L4, and then all of a sudden they needed that sacral coverage. But because of the spread of your medicine, for whatever reason, you just didn't get that spread quite far enough, or you couldn't physiologically get it, even though you might try, and they'll call you and say they need a bolus, they need a setup dose. And if they need a setup dose, you're gonna try to get it into that sacral, but there's really nothing you can do to get it into that sacral space without positioning. And if they're transitioning, I will usually sit them up to try to get gravity, because I know I gotta push that medicine down into their sacral nerves. It's the hardest part to get, and that's why moms think their epidural failed or stopped working. Well, no, it technically didn't stop. It just that as you transitioned, the spread wasn't where you needed, and there was nothing we could do about it really. You can try to do all you can to try to help gravity pull it down, without either pulling it out and trying to put an epidural down sacrally, which we don't do, right? Or do a spinal block where you can get porosity that sinks down, which we typically don't do as well. So they just kind of have to, at least transitions usually pretty quick for most people, if they get uncomfortable. Now, having said that, some people you get great sacral spread, and they may be totally comfortable. And if people, when you're doing your initial loading dose and they say, oh, I feel it in my toes, it's warm, it's tingly, it's like, that's actually a good thing, because now you know you've kind of got that good sacral spread. And their epidural will probably work better than somebody that says, well, yeah, I feel it in my thighs, but I don't really feel it in my lower legs or toes. That might be, your brain should be thinking, they probably aren't getting great sacral spread. I can either increase my volume, change their position, increase gravity, or you could even consider if you're L3, 4, and you're like, and I wouldn't do this, but you could theoretically pull it out and go lower, L4, L5, L5S1 even, but that'd be unusual. You wouldn't do that just because. Okay. Any other questions on epidural? I stopped bleeding.